Chemistry 2 Exam 1 review session. We're going to go over everything that you've learned in weeks 1 through 3. And I'm going to ask some questions as we go, maybe tell a few stories. And we're also going to have a couple review questions towards the end. Okay? So let's go ahead and start with, why is my screen not flipping? There we go. Trace elements. Know the difference between what an essential and a non-essential trace element is. Also know which elements are essential and which ones are non-essential. Know how they're collected. We use these special blue top tubes like you see up here in the top right-hand corner. They're made in a very special facility that don't have anything that could interfere in the glass and leach out into the serum sample itself. We use atomic emission spectroscopy and atomic absorption spectroscopy for this type of testing. Here's the list that you need to be familiar with. Know that arsenic, cadmium, lead, and mercury are all non-essential, and they're actually quite toxic, right? Chromium is something that is essential. We need that for insulin and glucose metabolism. Copper is very important for enzymes. And then we talked quite a bit about iron binding capacity, transference, and ferrous iron. So I have a little box here. Know that the Fe+2 is the ferrous, which 2 of us, so it makes it kind of easy to memorize, ferrous and 2 of us plus 2, is found in hemoglobin. The ferric is the +3. That one's carried by transferrin. So know the difference between those. Manganese, molybdenum, selenium, and zinc are also essential elements. I do have a little note down here on pica. Pica is what can happen if you're deficient in certain types of things, especially if you were maybe iron deficient. It could make you want to eat dirt. Some people have other psychological disorders that cause pica. I one time saw on the doctors, I think, one girl ate 2 boxes of cornstarch a day. It's like a thickener, so I can't imagine how thick that would make your mouth, but just something that's out there, I guess. All right. Oh, man, jumping around. Okay, therapeutic drug monitoring was next. The importance of therapeutic drug monitoring is to make sure that you're not giving someone too much of a drug, that drug becomes toxic, or too little of that drug, so the drug doesn't kill off whatever bug you may be trying to get rid of. To know what the mechanism of action means, the site where the drug works. They travel through the blood bound to proteins such as albumin. They're cleared from your system via the liver and the kidneys. Okay? Remember how important the liver is for metabolizing drugs. And the half-life. Half-life is pretty important. We need to know the half-life of a drug so we know when to give the next dose. Be familiar with steady state and the hop down to MEC versus MTC. You want to be right in the middle of those. That's called the therapeutic range, right? Be familiar with the 5 pharmacological parameters that determine drug concentration. I call this LADME, L-A-D-M-E. Liberation, absorption, distribution, metabolism, and excretion. Know the order of that, okay? The next piece that's really important are your drug classifications. You're going to be asked, what type of drug is digoxin? Well, you need to know it's cardioactive. Or if we say, what is another name for phenytoin? You have to know it's Dilantin. So you have to know what these drugs do, okay? Are they seizure drugs? Are they antibiotics? Is it a cardioactive? Is it a psychoactive? Is it lithium? That's for manic depression, okay? So if you're given a drug, you need to know what category it goes in. There's probably at least 4 or 5 questions on that. So make sure you take note cards out of this list. Put lithium for manic depression on one side, psychoactive on the other, okay? No anti-epileptic? No, it's primidone. Or primidone is an anti-epileptic. All right. Next, we have toxicology. This is always a very interesting piece of clinical chemistry. Everyone always likes to learn about it. So we'll run through some of the different toxic agents. You just need to understand the different routes of exposure. You know, they can be inhaled, they can be ingested, injected, many different things, right? Acute toxicity is something that happens right away. So you take a drug, it becomes acute within hours. Chronic is something you may be exposed to over a long period of time, like in a workplace. So let's talk about what some of these are. Alcohol is also known as ethanol. Methanol, that's what you use in hematology. Okay, that's the fixative. That one is metabolized into formaldehyde in your body. Isopropanol is isopropyl alcohol. One time there was a guy who came into the emergency room where I was working, and I had to go draw his blood for one of these tox panels that included these, and he drank a whole bottle of isopropyl alcohol. He smelled like that. It just reeked of, you know, the prep pads that we used to draw blood. The whole room smelled like that. Ethylene glycol is the reason why I have little Fluffy up here in the corner drinking the antifreeze. It's very, very toxic to your kidneys, and it can actually crystallize in your kidneys, and we see those calcium oxalate crystals in the urine of people that overdose on this. Carbon monoxide, okay, we hear of people that have a car running in the garage or they have a dysfunctioning furnace, right? It has 250 times the binding affinity for oxygen. So if you are in a room where it has carbon monoxide, you won't be able to smell it or even sense it, but your body's going to absorb it before it will absorb oxygen. Then we have cyanide that binds to heme iron that can become quite deadly. That's what they used in the concentration camps in Germany. They told people they were taking showers, but instead cyanide gas came out. Then we have arsenic. This is found in things like rat poison, okay? Tasteless, odorless. Sometimes you watch like a murder mystery or, you know, what do you call those, mystery diagnosis show. One time they had a lady that was putting arsenic in her husband's iced tea and slowly killing him. Next are the drugs and drugs of abuse. So with these drugs, usually we use urine as a screening method. Okay, immunoassay is used on urine for screening. Now, if they want to do a confirmation test, we do something called GC mass spec. But with the urine, we can only give you a qualitative result because it could be diluted or it may be a concentrated urine. So you really can't say, okay, this person has exactly this much cocaine in their urine, because if two people use the same amount of cocaine, but one drank 2 liters of water and the other one had no water, it's relative to that. So it's just a screening method to say, yes, they've taken that drug, or no, they have not. First one is salicylate. Okay, that is known, that's aspirin, your typical aspirin. The next one is acetaminophen, and I really apologize for my spelling on that. Wow. Acetaminophen can actually cause severe hepatotoxicity. This is your typical Tylenol. My very last day, it's my last day or second to last day of working in a hospital laboratory, I remember this young man came through, I would say 17, in the emergency room, and his acetaminophen level was 200. A therapeutic range of acetaminophen is usually up to about 20, and his was 200. Acetaminophen is not going to kill you if you overdose on it. It's just going to put you on a liver transplant waiting list. So you always want to make sure that you don't take too much Tylenol. Next, we have amphetamines. Okay, there's quite a few things in that category. Sometimes we hear in the news about methamphetamines, crystal meth, things like that. Anabolic steroids we've heard of. Cannabinoids, THC, marijuana, right? Cocaine. The next big category is opiates. A lot of things in the opiates. We got the methadone, the hydrocodone, the oxycodone, heroin. Okay, those are all going to fall in your opiate classification. PCP are your hallucinogens. Barbiturates are often used in things like anesthesia medication. And then we've got the benzodiazepines. Benzodiazepines are like your Valium or your downers. One thing that we talked about very briefly, or even talked about at all, is the chain of custody. This is used for legal testing of the drugs of abuse. It identifies all people that were involved in specimen collection and transfer and the shipment of the testing sample. For example, when I worked at the first hospital I ever worked at right out of college was a huge hospital, and we all had to take turns going down to draw the drunk drivers. So the police officer would have a kit. You would go down there, and you would draw the patient's blood, or the person that was arrested, actually. You would draw their blood, and you and the police officer would sign it. You'd sign the tube. You'd put it in a sealed container. You and the police officer would ship it, seal it, and then ship it to the state lab for testing. This chain of custody did hold up to legal testing, and there were times that I did have to go to court to answer questions about that drawing process. So that's how the chain of custody works. It's got my initials or my signature on it, police officer's signature, the person who did the laboratory testing signature. So all of those people could potentially be subpoenaed to court. It was always kind of interesting if you did land in court. Okay, next section is hormones and pituitary function. Hopefully I've provided you with some easy ways to memorize some of this. But let's start with the hypothalamic hormones. Those are all your releasing hormones, plus dopamine and somatostatin. Thyrotropin-releasing hormone, gonadotropin-releasing hormone, corticotropin-releasing hormone, growth hormone-releasing hormone, that's an easy one. And then no somatostatin and dopamine, okay? They do what they sound like, which is kind of nice. The next we have the pituitary hormones, anterior and posterior. Please know that the adenode hypothesis is the same as the anterior pituitary. And here's how I memorize the anterior pituitary. We've got some flat pigs down here, right? Okay, they're all squished. Flat pigs like to lay in the mud, right? And ants are in the mud and they crawl over the pigs. So anterior refers to flat pig. Flat pig refers to all of these hormones, okay? F is for FSH, L is for LH, A is for ACTH, T is for TSH, P is for prolactin, and G is for growth hormone. The I is just there as a little extra. So that's how you know which ones come from the anterior pituitary, okay? So that does include the only two that are in the posterior pituitary, which is oxytocin and vasopressin. So if you know anterior pituitary and flat pig, you can figure out which one comes from which. So it's just you write down flat pig on your piece of paper and put down all the different hormones with it. So with the posterior pituitary, oxytocin is for labor and some lactation. Be familiar with vasopressin or ADH. Vasopressin or antidiuretic hormone. These regulate water balance. And if you have a deficiency of ADH, it can lead to diabetes insipidus. Insipidus causes intense thirst, so it sounds like sip, right? So what you do is you drink and you drink and you drink and you drink and you drink, but since your tubules don't respond to the hydration, because there's no ADH to help it, you just keep peeing. So you essentially just drink and drink and drink, and pee and pee and pee, and you dehydrate and die. Once these patients are given an injection of ADH, it completely reverses it, and they're fine immediately. So that is what the diabetes insipidus is. The next section is tumor markers. It's so incredibly important that you guys know that this is to monitor therapy effectiveness and disease recurrence, not to diagnose a patient, okay? There is an exception to the rule, PSA, okay, is one that we'll get to in a second. But make sure that you know it's to monitor therapy effectiveness. So once they do maybe a biopsy and an ultrasound and they diagnose that the patient has cancer, once they start treating them, they're going to draw their tumor markers every month or 2 months or however often it may be to make sure that the level is coming down. And once they're treated, they're going to keep track of it to make sure it doesn't go back up, okay? So you need to know what each one is for. Alpha-fetoprotein is for hepatocellular and testicular cancer. CA-125 is an ovarian tumor. I always think I had one baby at age 25, needed ovaries with that, right? CEA, colon cancer. Cancer eats anus, right? CEA for colon cancer. HCG is for pregnancy and testicular cancer. So if you get an HCG in a male, don't freak out. It could completely be possible. Okay. PSA, prostate cancer screening. So this is one that is used as a screening tool. It's one of the very few. CA-19-9 and 242 are colorectal, and 27-29 and 15-3 are breast cancer. The last one that I want to mention here is alkaline phosphatase. This one can be helpful to see if any cancer has spread to the bone. Because remember back from chemistry 1, alkaline phosphatase has liver and bone. ALKP, sometimes it's ALP, looks like ALPO, liver and bone. If cancer spreads to the bone, the alpha phos is going to be increased, especially the bone portion. A couple definitions here. Oh, geez. I've got the touchiest mouse here today. Oncogenes are activated forms of normal cellular genes. Know that definition. All right, adrenal function. Quite a few questions on this, but I don't want you guys to be afraid of it. I'll tell you exactly what you need to know here. Know what is synthesized in the adrenal cortex and what you find in the adrenal medulla. Adrenal cortex has things like estradiol, cortisol, and those types of things. The adrenal medulla has the catecholamines. Those are the fight or flight response type things. So if the car lands on somebody and little grandma's able to run over and pick up the car, that is an example of epinephrine, norepinephrine, that superpower that all of a sudden comes out. Those are catecholamines. So one of the things that can happen with catecholamines is somebody could have a pheochromocytoma. A pheochromocytoma is a tumor that just secretes catecholamines whenever it wants. Okay? So if you think about if you've ever had a panic attack or if you've ever had someone like jump up behind you and scare the bejesus out of you, and all of a sudden your heart is pounding, you're breathing really heavy, and you're just like in a sense of panic that scared you, people with a pheochromocytoma just have that sensation without anybody scaring them. So it causes that sympathetic hyperactivity where they're just like, oh my gosh, they got that anxiety feeling just all of a sudden out of nowhere. So they need to treat and get rid of that because it is secreting those abnormally. The next one is congenital adrenal hyperplasia. With this one, we see sometimes in females with ambiguous genitalia and some other types of issues that go on along with that. But how we test for it is 17-hydroxyprogesterone. See the steps to the angiotensin cascade that we see on the right? Think of somebody, we'll start on the bottom, who passes out, okay? So let's say I pass out cold on the floor. My kidney is actually able to pick up that drop in blood pressure. It's then going to step 1 here, release renin. Renin causes the conversion of angiotensinogen to angiotensin 1. Then angiotensin 1, by way of angiotensin converting enzyme, or ACE, is converted to angiotensin 2. That will cause a small rise in blood pressure, but that will act on the adrenal glands, this little cute guy sitting up on top of the kidney, to release aldosterone, which will make you retain salt. If you've ever eaten a ton of Chinese food at night and wake up the next day and your fingers are all swollen and you feel like you gained 10 pounds of water, that's because of something of the salt retention. That causes your blood pressure to rise. So when your fingers are all puffy from all that Chinese food, you probably have a little bit higher blood pressure too. That's from all that salt retention. All right, next we're going to jump down to some of these diseases down here. So you see I've got Conn syndrome. These are the big ones: Conn syndrome, Cushing syndrome, and Addison's disease. Those are the ones that I really want you to focus on. You need to know for sure what the aldosterone and cortisol levels would be of each of these diseases, along with some of the symptoms that I have over here on the right-hand side. With Conn syndrome, you have a very high aldosterone. We also see metabolic alkalosis, high blood pressure, and a low potassium. So his claim to fame is the high aldosterone, okay? Think Conn's, think high aldosterone. Let's move down to Cushing's syndrome. Cushing's has a low aldosterone, but a really high cortisol. He's the only one with a high cortisol. Cushing's and cortisol go together. The thing that's crazy about this is that your cortisol remains high all day long. So you normally have the cortisol level in the morning and then it drops down in the evening. If that cortisol remains high all day long, then it'll have Cushing's syndrome. We call it a loss of diurnal variation. Okay, so you're exposed to massive amounts of cortisol all the time. Gives you a big belly, gives you kind of a humpback, gives you a round moon face. It's very not desirable. The last one is Addison's disease, and I thought this was kind of interesting. My friend's dog was just diagnosed with this. Low aldosterone, low cortisol, low everything. Your ACTH is very, very high. ACTH comes from the pituitary gland. And what's happening here is the pituitary gland is telling the adrenal gland to release aldosterone and cortisol and things like that. But it can't. It doesn't work. There's autoimmune destruction of the adrenal gland. So for some reason, the body just decided to destroy it. Well, the pituitary doesn't get it. He's not that bright. He just knows to send more ACTH. Sends it, sends it, sends it, sends it, sends it. Nothing happens because it's destroyed. So that's why the ACTH is so high, but the aldosterone and cortisol are so low. Okay? Be very familiar with those. So like I said, anything that I have on this chart is very important, especially my notes off to the right here. All right, come on, there we go. All right, next section here is gonadal function. Not a lot of important things in here. I'll just hit on a few highlights of it. Know that testosterone comes from the testes. It's the most potent androgen in the body. Let's see, with the ovaries, we have some hormones, estrogen, progesterone, FSH, and LH. A little bit on here of what they do. Progesterone is very high in the luteal phase, and it helps ready the uterus for implantation. Know that ovulation is caused by a large rise in LH. Okay. FSH causes the release of an egg. So that, there's not a whole lot here that we really need to know, but we do a lot of lab testing on these things. Menstrual cycle abnormalities. Amenorrhea means no menses at all. Oligomenorrhea is very scanty. Hirsutism is on here. That is excessive facial hair in females, and that can be caused with hormonal imbalance as well. Estrogen replacement is something that we sometimes see with people that are going through menopause, and they have very low estrogen in menopause, which might be a reason they would do something like that. All right, switch slides. So don't want it to switch, it switches. And when you want it to switch, it doesn't switch. There we go. All right, thyroid gland. This one's near and dear to my heart because I do have thyroid disease. The purpose of the thyroid has many different things. It helps control body heat, metabolism, heart rate. So there's quite a few things involved with this. Now, you need iodine to make thyroid hormone, okay? It's made in the follicle of the thyroid itself, which is found kind of in your neck. And it goes to the follicular cell, to tyrosine, monoiodotyrosine, diiodotyrosine, to thyroglobulin, and then a lysosome converts it to T3 or T4. So here's what's really important. Triiodothyronine is T3. Thyroxine is T4. T4 is the primary secretory product of the thyroid. When I go to the doctor and get my thyroid tested, I get a TSH and a T4. The thyroid is controlled by TRH and the TSH, and I cannot begin to tell you how important this is. So looking at my little picture over here, hypothalamus tells the pituitary, this big ball here, to release TSH. TSH is released from the pituitary to the thyroid. The thyroid in turn then secretes T4 and T3. If T3 or T4 goes down, the pituitary sends more TSH. If T4, T3 is too high, the pituitary will send less TSH. So people tend to get this backwards quite often. If somebody has hypothyroidism, which is what we'll talk about first. If you have hypothyroidism, that's what I have. It's called Hashimoto's autoimmune thyroiditis. My thyroid does not work, okay? We'll just cross this puppy off here. This just does not work at all, okay? So oh, sorry, I just crossed off the wrong thing here. Where is my eraser? Erase that. There we go. Okay, so, my thyroid does not work. Cross that off. Let's start over. My thyroid was attacked by autoantibodies, so it does not work. My pituitary works just fine. So since my thyroid is not secreting anything, it's not sending any T4 out into the bloodstream. The pituitary can pick that up. So what he does is he sends more and more and more and more and more and more and more TSH. Just to keep sending it, trying to get my thyroid to release more T4, when in fact it can't. So what we find is that my TSH is extremely high because my pituitary is still sending it, but the T4 is very low because the thyroid is broken. So many people get this wrong, okay? Make sure you know if someone's hypothyroid, the thyroid's not working, that TSH from the pituitary is going to keep trying, okay? All right. I'll try and erase this. And my screen doesn't like me today. I'll try. Here, just do one thing at a time, I guess. Okay. Now we're going to move on to hyperthyroidism, which is called Graves' disease. Here is how Graves' disease works. All right. So you have my pen doesn't want to work here. There we go. You have a thyroid that works very, very well, too well. It's autonomously functioning, which means it will just keep sending more and more and more and more T4. Okay? It doesn't care. It keeps sending it. The pituitary goes, holy cow, we got way too much T4, so it tries to stop the TSH. It tries to shut it down. Somebody with Graves' disease or hyperthyroidism is going to have a really high T4 and TSH of sometimes 0. Okay? What's really interesting with this is sometimes it can be cancerous. There can be tumors that just release a ton of T4, so they have to actually remove the thyroid. Another thing they can do to knock it down, since iodine, the thyroid is the only thing in the body that uses iodine, they give radioactive iodine. So when that patient takes those radioactive iodine pills, the iodine just kind of destroys the thyroid from within. It's really very cool. Let's see. Sometimes we see goiters with thyroid disease, which is like a big lump in the throat. Probably not as often as we did in the olden days. The last thing of the slide that's really important here is the primary, secondary, and tertiary levels of dysfunction. If you have a primary hypothyroidism, that means there's something wrong with the thyroid. If you had a secondary hypothyroidism, that means there's something wrong with the pituitary. If you had a tertiary hypothyroidism, it would mean there's something wrong with the hypothalamus. So if you see a primary, secondary, or tertiary type of issue, know that primary starts with the gland itself, pituitary moves up to the next, and hypothalamus moves up to the top. All right, are you ready, Cassie? Cassie's our only one here, so she's going to have to answer these as best she can. All right, what is another name for Delantin? What is another name for Depakote, and what is another name for tacrolimus? You can type in the chat box. Delantin is also known as phenytoin. You know what? I'm going to get my little. Okay. Depakote is valproic. It is on tacrolimus. Tacrolimus is FK506. Okay. So Delantin is phenytoin. I don't have much help for that, but Depakote is valproic. They both have P's in them. I don't know if it helps you, but some people, it does. All right. Which drug has severe hepatotoxicity? I told the story about the guy that came in through the ER and this level was 200. Tylenol or acetaminophen, yep. Won't kill you. It'll put you on a liver transplant waiting list. Nice job. What is the initial acid-base status of an acetylate overdose? Salicylic acid. It's actually respiratory alkalosis from hyperventilation. So once they overdose on it, they start hyperventilating right away. That's one of the side effects of it, and that'll cause respiratory alkalosis. It will actually shift to an acidosis status later on, but that is the initial finding. Okay, what is the most common cause of Addison's disease and Hashimoto's disease in North America? Ideas? Hashimoto's is hypothyroid, but what is going on that's causing it? Something is destroying the adrenal gland and the thyroid. What is it? What is destroying those things? No thyroid function, right? But why? It just decides to quit? Or is there something ruining those two glands? Okay, autoimmune destruction. Okay, autoimmune destruction of the adrenal gland and thyroid. All right, which adrenal cortical hormone promotes sodium resorption by the renal tubules and affects water balance? Is it aldosterone, cortisol, calcium, or renin? Aldosterone is correct. Which one is not secreted by the adrenal cortex? Cortisol, estradiol, androstenedione, or epinephrine? No, not estradiol. Nope. Nope. Okay, it is, let me pull up my thing. Epinephrine. one is from the adrenal medulla. Okay, so epinephrine, norepinephrine are from the adrenal medulla. I always tell this story, and I'm sure people think I'm crazy, but Adam Sandler from Waterboy, when the chemistry teacher says there's something wrong with his medulla oblongata, he uses the word medulla, even though it's not referring to the adrenal gland. Adam Sandler has that fight or flight response where he runs across the room and he takes out the science teacher. Okay, so there's something wrong with your medulla oblongata. So think that the epinephrine, norepinephrine are those catecholamines that cause that fight or flight response. That goes in the medulla. Everything else goes in the cortex. All right, what does transferrin carry around your body? Yes, iron. What kind of iron? Ferric iron, iron plus 3. Ferrous is found in hemoglobin. Okay, close but yet so far away. Transferrin carries the ferric. The hemoglobin is the ferrous. Okay, plus 2. What is the disease called when someone's missing ADH or vasopressin? It's called diabetes insipidus. That's when you drink and drink and drink and pee and pee and pee and you end up dehydrating to death. In what disease do we see a loss of diurnal variation of cortisol? I know, Cassie, my brain's fried too. This Packer game really did all of us in. In what disease do we see a loss of diurnal variation of cortisol? This one is Cushing's. Okay, Cushing's disease and cortisol go together. This is a yes or no one, okay? Tumor markers used to diagnose? Big capital N-O, thank you. No, they're used to screen the treatment effectiveness and recurrence. Although PSA can be used as a screening tool. We're almost done. All right, what hormone controls metabolic rate, has an effect on cholesterol synthesis, and stimulates heart muscle contraction? I have a deficiency of this and take a synthetic version of it. Not TSH, no, it's thyroid hormone or T4. The hormone that controls all this comes from the thyroid. That is T4, T3, thyroxine, yep. TSH comes from the pituitary. That is no control in any of this. It just controls the thyroid's release of the T4. All right, and we have survived. Any questions?